About fluid management in the ICU. It's a very common topic, you know. We work together, I mean, and all the time it's always a question, you know, what to do, should we give fluid or not. So I wanted to go over some overview about fluid management. I'm going to tell you everything I know, and hopefully we'll get to the bottom of it, you know, and you will enjoy this lecture. So let's get started here. Actually, I don't have any disclosures, you know. But if you know anybody who can give me disclosures, I'm available on.
We'll work for
so I'll be happy to make some disclosures. Okay, so what's on our menu for today? So we're going to be talking about fluid management. Does fluid management really matter? How much fluid is enough? What are some of the tools to predict fluid responsiveness? We're going to talk about static versus dynamics. And we're going to try to see if we have some time. Also, we'll touch on the role of echocardiography in predicting fluid responsiveness in the ICU. I mean, this is a chapter by itself, you know, but we're going to try to see if we can highlight some of the important stuff. So let's get started here. So does fluid management matters? What do you guys think?
Yes.
Yes.
I do. Okay. So if we look at the definition, dictionary definition of perfusion, right? I mean, it's the injection of fluid into a blood vessel in order to reach an organ or tissue, usually to supply nutrients and oxygen. That's the definition, dictionary definition of perfusion. So what's malperfusion? It's a shock, which is bad. It's a life-threatening medical condition where insufficient blood flow reaches the body tissue. As blood is the body carrier of oxygen and nutrient, insufficient flow leads to a deficiency in these components, which are necessary for proper tissue functioning. So this is a dictionary, you know, definition of perfusion. So how are we going to translate this definition into the medical field? So this will bring us to some, you know, one-to-one physiology. I mean here, which is the oxygen delivery, right? Perfusion is the oxygen delivery, and it's a very important formula. And the oxygen delivery, the VO2, is the cardiac output times arterial oxygen content. If we want to break it down a little bit here, there's going to be something here. Anybody knows what's in this formula? What's missing? Which is the most important thing of our topic for today?
Blood pressure.
Okay, let's look. So we're going to have something called the stroke volume. The stroke volume, very important, you know. I mean, because little bit changes of the stroke volume, you know, are very important, you know, for the oxygen delivery, you know. Heart rate, of course, is a compensatory mechanism, you know, but the stroke volume is the most important, you know, component. And our ability to be able to predict and know about the stroke volume, this will help us, you know, to understand a little bit more physiology. So when we talk about volume responsiveness, the question, you know, that needs to be asked here: with cardiac output, tissue blood flow, oxygen delivery, remember the dictionary definition of perfusion, does it improve with administration of fluid? This is a big question, you know, we're gonna try to ask. So, you guys know about the Starling curve, and this is very important. I mean, you know, this is important important here to understand it so we can understand physiology. So if you look on the y-axis, what there? Stroke volume, right? On the x-axis we have preload, okay, which is the force descending the heart and the diastole. And this is the Starling curve. So let's break it down a little bit here. So if we look at those two squares here, I mean, we have A, which is like on this side here, and we have B, which is on the edge. So we have the steep, you know, the steep portion, you know, the curve, and we have also the plateau on the top. And the question is like, where the patient stands. If patient is here, so we give a little bit preload, the stroke volume is going to get better. You keep giving until you reach here, B, which is volume non-responder. So the Starling curve is very important, you know, and understanding where your patient stands on this curve will help you to determine if the patient is going to be fluid, volume responsive, yes or no. Okay? Is the patient on A, which is volume responsive, or a patient on B? Because on B, whatever you give fluid here, the stroke volume is not going to improve. Okay, and then we're going to end up with complications, you know, of
Dr. Kosseifi, you want clicker?
Yeah, thank you. Because I have to put this in here.
Can we turn the light on, please?
Sorry.
Thank you.
I don't think we have a port here. We have an extra port. Okay, thank you. Okay, let's turn it to light off and see if it is working. Will it have a laser too?
No laser.
We'll give it like a second and then.
You have to tell it to use it, like open it up or something. There you go.
Oh,
No.
you see it?
Blinking.
Well, that's good.
That's it. I think we should be. Oh, there it is. Okay, so this is paintings that was taken from the sepsis campaign and the clinician, which he's attacking the three heads of sepsis, right? We have hypoperfusion, hypotension, and organ dysfunction. Okay, so let's take this case. You know, we have a 55-year-old female patient, hypertension, rheumatoid, diabetic, alcoholic, presenting to the hospital with productive cough and dyspnea. Chest X-ray revealed bilateral consolidation, and temperature is 102, blood pressure 75 over 40, heart rate 130, respiratory rate 29, and her SATs is like 86. I'm sorry, this is a male, not a female. Of course, cultures were obtained. Those in Zitromax Vancor, but she's, you know, alcoholic, rheumatoid, you know, and 30 C per kg, right? Sepsis protocol implemented here. So, on her exam, of course, she was respiratory distress, her extremities are poor, capillary refill is poor, lung auscultation, she had some crackles, but no abnormal cardiac sounds. EKG was okay besides sinus tachycardia. Urine output was below 20 in the past 2 hours. 1.5 liter normal saline, her CVP is 15. So this is arterial line was placed, and the tracing here.
She's intubated?
She's not yet. And that's her X-ray. This is his X-ray, basically here. Trachea, midline, you see like bilateral infiltrate, both lungs, and central line was placed. CVP is 15. So now, intubated, temperature 101, blood pressure 87 over 50, heart rate 115, respiratory 22, her SATs 90. We had to put her on people 16 and 100% FiO2 to get her SATs, more than 90. So she turned into So intubated, line in. Question here: what's the most appropriate management? So dobutamine for severe LV dysfunction, perhaps alcoholic cardiomyopathy, sepsis. Start norepi for hypertension related to surge sepsis. PPA, maybe PE. IV fluids, palliative care consult, close the case. So I'm giving you options here. I'm giving you options,
How about put an A-line?
Okay,
You got one.
Okay.
You got an A-line.
How about we do some measurement for our
Some measurement. So question here is like, right? And most of you got this, so is she wet? Is he wet? Is he dry? Or even bolus, not too bolus here. So we need to assess the volume, right? We need to know what's going on here. And most importantly is the stroke volume, because this is really what's going on.
But the CVP is 15.
Yeah, so if you
But-
get, yeah,
But
it's
the
coming.
peak was 16,
Yes.
so you have to do a formula for that too, right?
Yeah. Let me get over
Thank
couple of
you.
slides.
Let him do his talk.
He said to give
you all those answers already.
Yeah. So we need some valuable indices to guide our therapy here, right? You guys agree? It's hard. It's not the. And the thing is too little fluid, you're going to precipitate renal dysfunction, cardiac ischemia, organ failure, too much fluid, we're going to end up with lung edema, chronic ischemia, congestion, acute coronary syndrome, organ dysfunction. So too little is bad, too much is bad. So we're going to find something in between. When we look at the microcirculation, especially in sepsis, the microcirculation is, there's lots of alterations that will occur there. And some of those disturbances are congestion and hemorrhage, in addition to edema formation. Okay, this is why you need to know how much you want to get. And this is, the microcirculation is very important in sepsis, you know, and any alteration, disturbance of the microcirculation, even though the numbers might look good, outcome is bad. Okay, so edema can occur and congestion also can occur. Let's say, what are some of the risks associated with fluid challenge? So too much fluid. Increased risk of bleeding. Blood pressure goes up, you know. I mean, if they have bleeding, you know, they can bleed. Increased cerebral edema, pulmonary edema, diffuse interstitial edema, electrolyte, sodium, potassium, right? Dilution anemia, dilution coagulopathy. It's getting D5, you know. I mean, acute kidney injury, coagulopathy, I mean, with colloids, you know. So fluids aren't really any safe, you know. You want to know exactly whether the patient is volume responsive or not. I mean, because there are lots of disturbances that occur here, you know. So it's not just guessing, you know, okay, I will give fluid, not give fluid, especially when talking about like severely sick patients, you know, I mean, like our case we present. So if we look at the early goal-directed therapy, you know, this was back in 2001 when we had the early sepsis guidelines, you know, sepsis campaign. You know, more fluid is very helpful in the first 6 hours. Okay, but how much to give? And you look at the diagram here, as a protocol. I mean, they use CVP and SpO2, and this was, you know, the protocol at that time by many river, you know, back in 2001.
I remember that.
Yeah.
Yeah.
So fluid is good, it's important, right? On the other side, if you look at fluid, it's a conservative arm, you know. So basically, they diurese those patients in the ICU to make sure, like, you know, the CVP is below 4, wedge below 8. The liberal, they allow the CVP to be a little bit higher, 10 to 14, and the wedge to be less than 14 to 18, you know. So, and if you look at the net balance in 7 days, it's basically the conservative, and we're talking about the cumulative balance here, is minus. So they were negative at 7 days, and the liberal were positive, close to 7 liters. So those two. So what happened here? When you look at the Kaplan-Meier curve here, the outcome was conservative fluid reduced the duration of ventilation and ICU stay without compromising non-pulmonary organ function. As a conservative one, you know. So I showed you previous slide, the early goal-directed therapy, you know, where fluid is important, you know, of course. But I showed you also on the other side where fluid also fluid restriction, you know, and having a negative cumulative balance at 7 days, you know, has been treated with reduced ventilation ICU days without compromising non-pulmonary organ function. So this is why we need to have some more valuable indices to guide our therapy, you know, and this is something very, very important as well given this talk. So this brings us to other question here.
Sorry, it's a gas for 31 who's climbing out of bed. Can we extubate her?
Yeah, please. Thank you. So how much fluid is enough? And what are some of the tools to predict fluid responsiveness? Okay. And this brings us to the same question before. Will cardiac output, tissue blood flow, oxygen delivery improve with fluid administration? So let's take a summary of some of the hemodynamic monitoring tools that we have available. So we look at the static measurements on this side. And the static measurements, like you're taking a snapshot. Dynamic measurements is like, you know, a moving picture. Okay, it's like a video. Under the static measurements, of course, we have history and physical exam. Let's say a patient been having diarrhea for 2 weeks. I mean, there's no brainer here. It's like he's fluid, right? I mean, he's dehydrated, you know. You can look at some laboratory data, BUN, creatinine, bicarb, lactic acid, you know, mixed venous oxygen saturation, urine output, you know. Mental status, which is important now in the QSOFA, which are the sepsis 3, you know, guidelines. This is the bedside assessment. Chest X-ray, CVP. So all those are static. On the other side, we have some dynamic measurements, which are very important because it tells you, like, you know, minute by minute, second by second, how the patient is doing, and you'll be able to assess the volume status and the stroke volume. We have the change in pulse pressure, variation, change in CVP, or variation in CVP, echocardiography, and pulmonary artery catheter. Okay, this is what's under dynamics. Okay, so let's start talk a little bit about some of the static, like urine output. Okay, so I'm going to tell you everything I know here. Okay, because sometimes you can use some of those things to kind of put it together. I mean, it's not just one number, you know. So urine output. I mean, of course, urine output is an important tool to assess adequate perfusion to the kidney. So this patient is making urine, you know, and to define adequate renal perfusion, he has to be able to make more than 0.5 cc per kg per hour, right? We can check a urine sodium and fraction of excretion of the sodium. If it is below 1%, this can tell you, like, you know, this is a pre-renal, right? If it is greater than 1%, it tells you, like, it's post-renal. So it tells you it's pre-renal, you want to give fluid. But this can be forcibly raised by diuretics. If the patient is already on Lasix, then the excretion of sodium in the urine is going to be altered by that, so you can't really rely on it. A better marker for the renal perfusion, or basically the fluid status, is the fraction of excretion of urea. We have BUN, we have urea. And I know we don't do it here, but if the patient is on Lasix, this is a good calculation or marker that tells you about is it pre-renal, is he dry, this is why he's not perfusing the kidneys, or is he, you know, renal, like, you know, does he have ATN or not? So the fraction of excretion of urea is actually on Metcalc. If you put like fraction of excretion of urea, so you collect the urea and the urine creatinine, and there's a fraction calculation on Metcalc, and if the level is below 35%, this indicates pre-renal, means like volume depletion, so you need to give fluid. If the level is like, you know, more than 50, 60, 70, this indicates ATN. For patients who are on Lasix, where you cannot use the fraction of excretion of sodium. Is it clear? This one here?
Yes.
Okay. So on the other side, you know, what we call FeNA, or fraction of excretion of sodium, can be forcibly lowered by, if the patient has already ATN. IV contrast can give you a forcibly low fraction of excretion of sodium, but the patient will be not pre-renal, he will be, you know, adequately, you know, he's not volume dehydrated. Tacrolimus, you know, cyclosporin, glomerulonephritis, all those can give you forcibly lowered fraction of excretion of sodium. So we don't use it, but on initial encounter, sometimes we look at it, but you need to know the things that can cause a false positive and false negative, you know, fraction of excretion of sodium, and try to come up with, you know, with the right decision. So let's move on a little bit here about what about the chest X-ray. So
Call to
428 nurse.
from
so the chest X-ray.
H.
accept.
I know pretty much most of patients will get a chest X-ray, right? And sometimes it's important, you know, to look at the X-ray and determine, you know, is the patient volume depleted or volume overloaded? And very important, you know, to focus on this area here. This is the vascular pedicle. And the vascular pedicle is like from superior vena cava, the border of the superior vena cava and the azygos vein, to, you know, where the carotid artery. Yeah, so it's pretty much this area of the mediastinum at the center, where you'll be able to assess, you know, also if the patient is volume overloaded or volume depleted. So let's get a little bit more details. So what are some of the stages like of heart failure? We have 3 stages. Stage 1 is where you start having broadening of the vascular pedicle width. So the vessels, the IVC becomes more congested, and the vessels in the mediastinum becomes congested, and then this is going to become widened. Stage 2 will have like interstitial edema, such as curly V lines, and I will show you some examples. And, you know, stage 3 we'll start having like pleural effusions and also more alveolar process, you know, consolidation. Okay. So this study was done on ICU patients, vented ICU patients, because, you know, sometimes when you take an X-ray on ICU patients like, it's not like, you know, a like PA and lateral. I mean, it might be like semi-erect or like, you know, supine. I mean, so it's hard to sometimes interpret. But this study was done on patients who are vented in the intensive care unit, and to trying to figure out, you know, if the patients were volume overloaded or not. So we mentioned about the vascular pedicle, and this is something, you know, we can measure. So basically it's from the end here, where the IVC goes into the right atrium, and there where, you know, the carotid artery, you know, leaves the aortic arc here. So this area. I'm sorry, I wish I had a pointer right here. So when it comes to the chest X-ray, you can do the same thing. As I said, this part of the mediastinum here, you draw a line, and then you draw the perpendicular to this line, and where the superior vena cava is going to meet the right atrium. And at this level here, this will be the vascular pedicle width. And if this is more than 63 millimeter, and the cardiothoracic ratio is more than 50%, means we have enlargement of the heart, and so this will indicate more of volume overload. Okay, so by just a snapshot, you know, you can look at this vascular pedicle width and be able to tell where your patient is at. And sometimes you can look at trends. Patient in ICU, on ventilator, every day they will have like an X-rays. So you can do this calculation, and anything that goes up by 20% or so, this indicates volume overload. Because this is here.
Is this right pleural effusion too?
He does have a little bit, yeah, pleural effusion on both sides, you know what I mean, and you see the hilum congestion, you know. But sometimes it's hard really to appreciate the effusion on an X-ray well, unless it's like significant effusion. You do a scan and you see effusion, because there's some of the time it will be like subdiaphragmatic, or on top of the diaphragm, subpulmonary process, you know, so you might not see it all the time.
Oh.
Yeah, but here, for instance, like this is another X-ray, the VPW.
Wow.
Here to here, and it's like 51 millimeter. It's below 63 millimeter, so the patient is not volume overloaded. So what they did in this study, you know, they did some statistics here, and of course, they come up with a cutoff of 63 millimeter on VPW. Anything greater than 63 millimeter indicates volume overload. Anything below 63 millimeter indicates, you know, volume depletion. So this is a static marker that's available for you. I mean, you can look at it. Same as the urine output, you know, and urine electrolyte like FeNA and the fraction of excretion of urea. You know, those would be also something that the nephrologist, you know, will look at.
How did you get that calculation?
This is like you can do the calculation on the packs.
Oh.
So yeah, so there's like the distance. You can measure the distance.
Okay.
And it gives you automatically on.
You'll have to show me that. Yeah.
But you have to do it, nobody
No,
reports
everybody
on
can
it.
do it.
But I mean, nobody reports, this is your,
No. This
Yeah,
is something like, you know, it is there. That's
Got
why I
it.
wanted to be
it's
aware
just
of
a
it.
tool.
And it's a tool, I mean, that, you know, can help you sometime to understand, because you guys, I mean, are involved in the care, I mean, and you're checking on the patient every day. And when you look at the X-ray, sometime you will be able to tell where we are. But this is a tool that's available. And, you know, I personally, you know, rely on it sometime, you know, if I don't have like, when I look at the X-ray as part of my review, and then I think we were talking about the VPW, you know, recently also, I mean, yeah. So remember, VPW, more than 63 millimeter overload, below 63, volume depletion. Okay. So there's something also called azygos, diagos vein. This vein that comes from the inner costals and feeds into superior vena cava. You know, you guys heard about this vein. This is the vein here, azygos vein. And this vein also is important sometimes, because fluid, sometimes when they back up, when the patient is overloaded, this vein will become distended. And you can see it on the X-ray if you look for it. And this for instance, this is where the azygos vein is. And when you do the VPW, you're going to start from here, the azygos vein, all the way to here, this distance. See it? Here. So it's there, and we can measure it. 9.7 millimeter. It depends sometimes on the position of the patient, if it's laying flat or positional, you know. But somebody in ICU, if the azygos vein diameter is more than 15 millimeter, this is volume overload. Okay, so I want you to train your eyes on looking at. You see, this is where the right main stem, and this is the azygos vein here. Yeah, so on the other side of the carina, that's the carina here, right main stem, and this bump here, the azygos vein. So I want you to be aware that those things are already there, and we look at it sometimes when they are available. Now looking back at our patient here, so we're going to do the VPW, and this is where the left carotid, mediastinum, and it was 60 millimeter on him. So it's an error. You know, even so we look at the X-ray and see like, oh, looks bad, you know. But you have to look at this VPW, you know, to see how wide it is, you know, because the VPW is below 63 millimeter, and even if you see all the stuff, which can sometimes be in like pulmonary edema, you know, it doesn't indicate volume overload. Okay. Now sometimes you can have like, you know, what you call non-cardiogenic pulmonary edema. It's not related to volume overload, but it's like stress to the alveoli. This is a different chapter. But here we're talking about volume overload or not volume overload, give fluid, not give fluid, and if we give fluid, what's going to happen to the cardiomyopathy? Again, this is here 60 millimeter also just to show you the VPW. Curly B lines, those you see, the curly B lines here, the layering, this is a sign of stage 2 pulmonary edema. And of course, when you start seeing this widening here, VPW, this is stage 3 pulmonary edema. Okay, so here the wedge pressure is going to be 25 or more, you know, overloaded. So stage 1, we talk about stage 1, the VPW gets wide. Stage 2, you start seeing like the curly B line and a little bit congestion, and stage 3 is like overload. So those indices, you know, tools we look at, you know, and sometimes a little bit details here. The radiologist sometimes can do what we call the Hounsfield unit. I don't know if you guys knows about the Hounsfield unit. And the Hounsfield unit is basically a CT scan unit where minus 1,000 is air, plus 1,000 is bone. Okay, so you look at the density and you come up with a unit. So it's a scale. Water is 0. Okay, so the lung usually is like, you know, between 600 and 400. You know, and like for instance here. This Hounsfield unit is 600. It's lung tissue, dry lung tissue. Once you start getting closer to 0, so minus 430, this can indicate more water in the lungs. You know, if it gets more, less like positive, this can indicate blood also. So the Hounsfield unit sometimes can help you. I'm just giving you a little bit more details here because sometimes, you know, like supine upright, you know, somebody is supine and then you put him upright, clears up. This is fluid. Right? I mean, so if they took an X-ray where he's supine and took an X-ray where he's standing. The fluid shift is fluid. Okay? Okay. Yeah, sure.
Sorry to,
Yeah.
you said the azygous vein, if it's greater than what?
15 millimeter.
15, okay.
15 millimeter, sure. Okay, this is a patient I just saw yesterday, actually. I mean, day before yesterday, on 5th floor. And I stepped into the room, you know, they consulted me for this X-ray. And when I stepped into the room, you know, he was eating...
2 bags?
I grabbed, you know, I grabbed the, you know, the chips from his hands, you know, I mean, he's going there. His EF is like probably like, you know, 25% or so. I mean, the guy was looking at me. So I saw this chips, you know, all the chips. I took it away from him. He felt bad, like, you know, almost like, you know, give me the look, you know. I mean, he likes chips, you know. And when I release him, you know, and I instruct him to take like, you know, unsalted. You know. Sometimes you would find, you know, the answer, you know, I mean, in the patient room, you know, I mean, yeah, I felt a little bit bad taking this, or like, you know, like. Okay, so let's get back to our patient. So we talked about the X-ray, remember the VPW, remember, you know, the azygous vein, you know, those important sometimes to when I look at the X-ray, and the stages, you know, of heart failure. Now going back to our case, I mean, so he's intubated, he's on PEEP of 16, and CVP is 15. So let's talk a little bit about CVP. So CVP is under static measurement. So Maxwell, he's well-known critical anesthesiologist. I mean, back in 1965, he mentioned CVP is an index of right ventricular function rather than an index of blood volume. It reflects the relationship between the volume of blood presented to the heart and its competence as a pump. So it's a pressure, okay? It tells you about the preload, but it doesn't tell you about preload responsiveness or volume responsiveness, basically. So we have lots of studies, you know, I'm just gonna pass click, 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 because the conclusion is the same. Cardiac filling pressure are not appropriate to predict hemodynamic response to volume challenge. This is a study like we've done on CVP, and it doesn't matter, you know, CVP less than 5, less than 12, you know, it doesn't help assessing volume or doing a volume assessment. The central venous, the CVP predict fluid responsiveness. This was an article in Chest, 2008. And you see, when you see those dots all over the place, not close to this midline, means it's bad, okay? And, you know, this study demonstrates that patient with low CVP may have volume overload, and likely was patient with high CVP may be volume depleted. So, there's a very poor relationship between CVP and volume responsiveness, and we should not make a clinical decision regarding fluid management, just based on CVP. So, CVP, let's look at the heart. That's the beating heart, So, where is this right atrium here? That's the right atrium. Very soft, very soft. And it's very sensitive to, external pressure. Somebody is on the ventilator, It's not like the other ones. It's not like the LV, the RV. This is where we get in the CVP, superior vena cava and the right atrium. So it collapses easily. So the pressure is not going to tell you about the volume here, So this is where the CVP comes from. It's a poor estimate of volume, and it's the number gives you pressure, but it doesn't tell you about volume status, which we should not rely our decisions, based on the CVP, which we've been doing in over. So CVP, it tells you about preload, but it doesn't tell you about preload responsiveness. So it's someplace here, but there's no correlation with the stroke volume. Therefore, you don't know where your patient stands on the Stirling curve. Therefore, you cannot make any decision about fluid. So this is an article from Merrick, and the conclusion here. And I printed some important articles. I have 3 articles, state of the art articles for you to read. I would like you to take a peek at some point. But this is one of the conclusion. CVP and static markers of cardiac preload. Please stop using it for predicting fluid responsiveness. This was the conclusion. Of this article.
Simply stop using CVPs on our patient.
Let's get back to our patient. What about
We're not checking it.
So we get the mixed venous oxygen saturation, SVO2, 65. Okay, yeah, the central line, we get one, right? So does SVO2 help us to predict volume responsiveness? The answer is no, okay, because SVO2, it doesn't provide an accurate estimate of preload or a measurement of contractility, It tells you about the microcirculation, Like 65 indicates septic microcirculation. So the tissue, is not absorbing, the oxygen, so there is issue with microcirculation. But it doesn't tell you about volume fluid responsiveness. It's nice to have it, but it's not a marker, Now, if you look at the early goal-directed therapy, it's here at the bottom.
We used to put those lines in.
Yeah. So it's at the bottom, It's part of the oxygen delivery formula, but it's not a surrogate for the stroke volume, which is very important here, So it's nice to have it, but it's not a big deal. What about pulmonary artery catheter, Yeah, so I think most of you are kind of familiar. Of course, we haven't done much of it, and because it's been subjected to greater scrutiny, than any other monitoring technique. We had lots of negative trials, and it hasn't shown that really improved survival or outcome, in patients, and the use of PAC, has dropped significantly. Here I put some negative trials. Of course, we don't like to talk about or go over negative trials, but there's lots of negative trials in those patients. You can see ARDS, heart failure, high risk surgical. None of those studies, was positive. Again, we still use them in cardiovascular ICUs, post-CABG. I don't think really it has really increased mortality. I've done some before, you need to know how to use them, but so far we don't have a backup or any studies showing that, the Swan-Ganz or the pulmonary artery catheter is helpful in managing fluid, in this, especially in septic population. There's no really, we're still using it in cardiac patient, post-cardiac, and OBGYN, most of the time, but otherwise, there's no, it doesn't help, it doesn't really help you to predict, volume responsiveness. And this is a study here that they look at the correlation between, the parameters that you obtain from, the wedge pressure, and different, parameters. And it doesn't really help you to determine, volume responsiveness. So it tells you about the preload, but it doesn't tell you about preload responsiveness. Okay. So CVP, wedge pressure, were major association endpoint in the early goal-directed therapy. So I think now we're waiting until we get the new guidelines, and I have some protocols at the end I would like to share it with you also. Both are very poor predictor of fluid responsiveness, and we should not be using them. So going back to dynamic assessment, volume responsiveness, same question. We're cutting output, tissue blood flow, oxygen delivery, improve with administration of IV fluids. Okay, so I think the question here to ask is, can the RV take it? Can the LV use it? Right? So, what is the perfect volume status monitor? It has to be fast, because we're dealing with sick patients, critically ill patients. It has to be easy to learn, and it should be validated, in all critically ill patients, medical, surgical, trauma, neurosurgical, and it should be available outside the ICU. Sometimes you want to assess the patient before he comes to the ICU, and it should give you an easy answer. It should not be complicated. So, of course, we can take advantage of the heart-lung interaction, especially if the patient on the ventilator. Let's talk a little bit about the pulse pressure variation, okay? And a little bit some physiology about how the pulse pressure variation can be helpful in volume responsiveness. So during inspiration, let's say we have somebody on the ventilator. So we give him positive pressure. What's going to happen with this positive pressure? The pleural pressure and the transpulmonary pressure is going to go up. So we're giving them pressure. We're inflating this lung during inspiration. So how the RV and the LV is going to act? So this positive pressure is going to decrease the RV preload. It's going to squeeze on the RV. And increase the RV afterload. What's going to happen is going to decrease the RV stroke volume. So with positive pressure, the RV is going to struggle. The stroke volume is going to go down. And this is during inspiration. Now during expiration, because there's like 45 seconds or so until you get the circulation delay, the circulation delay is going to cause decreased LV stroke volume during expiration. So inspiration, the RV stroke volume is going to go down because of the squeeze. The LV stroke volume during expiration, because of the delay, is not going to get enough, and the LV stroke volume is going to go down. What about the LV? During inspiration, the LV preload is going to go up because we're squeezing the blood in the lungs, and we're giving the LV a good fluid bolus. And the afterload is going to decrease. So the LV is going to get more stroke volume, okay, during inspiration. So if we take this variation between the inspiration and expiration for the LV, during the inspiration, the LV stroke volume is going to go up. So this will be like the maximum pulse pressure. During expiration, the LV stroke volume is going to diminish, it's going to go down. So this will be the minimum stroke volume or the pulse pressure. So if we put it together here, into inspiration and expiration, we said the LV stroke volume during inspiration is going to increase. This is what is going to be the pulse pressure maximum. So the pulse pressure is the difference between, systolic and diastolic here, and it's the highest. The pulse pressure minimum is during inspiration, which is going to be the lowest here. So if I take those two variables during a respiratory cycle, I can get the formula of the pulse pressure variation. And the pulse pressure variation is going to be the difference between those two, because we expect that the pulse pressure is going to be surrogate for stroke volume, divided by the mean of those two, multiplied by 100. And we get the number. And this number is going to tell us where our patient stands on the starting curve. Is he point A, volume responsive, or is he at point B, he's not volume responsive? And in this way you'll be able to tell where the patient stands. So we can use the pleural pressure change, which is a constant perturbation to circulation. This is like a dynamic, so it's like a video. It's like a snapshot, and we can assess, and challenge the circulation. So what's the cutoff here? So Michard, he's a big name in pulse pressure variation, ICU, and as I mentioned, the pulse pressure is surrogate for the LV stroke volume, which is a very important one in the formula of oxygen delivery and perfusion. So pulse pressure variation more than 13%, fluid responsiveness. Okay, so we have variation. If we don't have variation, it's narrow, means those vessels are already overloaded. So your patient is not gonna benefit from volume. So pulse pressure variation more than 13%, greater than 13%. Where patient is it A or B on the Starling curve?
A.
A. Pulse pressure variation below 13%, B.
B.
Pulse pressure variation on A more than 13%, we give fluid. Pulse pressure variation more than less than 13%, B, we don't give fluid. Okay, so this is something important, dynamic, and we can. So here, I mean, the study, kind of had side-to-side comparison between the wedge pressure. This is a wedge between the CVP, between the change in pulse pressure variation. Okay, so we have all those, and this is the ROC curve, and basically here, pulse pressure variation, delta PP, has the highest sensitivity and specificity than the CVP, which is here, than the wedge pressure. Okay, the other one is the change in systolic pressure. It's like when you check for pulsus paradoxus. We don't do it, but it's in Europeans, they do it. But the change in pulse pressure variation was way much better, than the other ones. And look here at the statistics, pulse pressure variation, area under the curve, 0.94, the highest, the rest, falls here. CVP, 0.55, nothing. Yeah. So, what are some tips and tricks, for pulse pressure variation, which we need to know about? Patient has to be in normal standard rhythm. If he's in atrial fibrillation, he won't be able to get it. Because the kick, the contractility of the LV is going to be affected, therefore the stroke volume is going to be variable. So it's going to be tricky. Patient intubated mechanical ventilation, no spontaneous, he should not be breathing over the ventilator and fighting, because you won't be able to use the interaction between the lungs and the heart. It won't work. Tidal volume has to be at least 8 cc per kg. This is where's the study. So if you have an ARS patient, 6 cc per kg, you might not get a good data. You might need to maybe try to consider a little bit going up, on the volume to get the effect of the positive pressure on the RV, on the LV, and yeah. Should not have an open chest, I mean, it won't work this way. Yeah. So, I know we've done it in the ICU here. We just want to kind of remind a little bit remind how we do it. So we go to the arterial line. The speed normally is set at 25 millimeter per second. We change the speed to 6.25. So we want to zap it. We want to, compress, those waveforms. And then what's going to happen? You're going to have this compressed, those compressed waveform. And on the same side, you can also get the respiration. So you're going to look at the maximum pulse pressure and the minimum pulse pressure. And all what you do is just freeze the screen. And when you freeze the screen, you're going to have the cursor there. And then you can go up on the cursors to be able to get the maximum pulse pressure and the minimum pulse pressure. And this is the maximum pulse pressure, minimum pulse pressure here. And then we'll come up with the formula, okay? And then we'll come up with, so if we calculate this case, 109 minus 91 divided by the mean, which is 100, multiplied by 100, so you're going to get like 18% pulse pressure variation, which is point A or B?
B.
A or B?
18.
18. A.
Oh, that's great.
So volume responsive. Yeah, A, remember. So A, point A, volume responsive. Okay, so we have, it's more, so more than 13%, okay? So this is the formula here we talked about, has a high sensitivity and specificity, our patient, let's say, had 18%, so we give him fluid bolus, and the answer here was IV fluid for hypovolemia, if you go back. So, he's on PEEP of 16, and this was a case actually last Saturday, this Saturday at downtown. This patient, yeah. Nathan was helping me with this patient, and I have Josh also. So Nathan called me and said, Dr. Kosseifi, his creatinine now is 2.6. He had a normal creatinine, and his BUN is 75, and he was on PEEP of 16, and we started him on levo, went up to 16, and vasopressin 0.04 to keep MAP 65. So what do you want to do? So I want to show you a couple of slides here, and I will tell you what we did, which was very helpful for the patient. So our patient had ARDS, acute respiratory distress syndrome, and judging the fluid, the volume status is not easy. and now we're dealing with organ perfusion and the kidneys. If you look at this study, the change in pulse pressure or pulse pressure variation predicted the decrease in cardiac index with the addition of 10 of P. So basically, if the patient, the higher the pulse pressure variation, so means that the patient is A, he's dry. If you add PEEP, then you're going to have decrease in cardiac output. Okay, so it's very important, you know, when we have somebody ARDS, to do a pulse pressure variation and make sure, like, you know, his pulse pressure variation is below 13. Patient has to be tanked up before you crank up the PEEP. If you crank up the PEEP on those patients, you know, you're going to precipitate low cardiac output, you're going to precipitate hypoperfusion. So knowing doing the pulse pressure variation, somebody with ARDS, and knowing where the patient stands is very important, you know, because if the pulse pressure variation is more than 13, I want to give fluid, tank him up, recheck it, bring it down to below 13, and crank up the PEEP. In this way, the stroke volume and the cardiac output won't be affected. This is something very important. So what we did, sorry, I think I'm going to tell you in coming slides here. I have this video here, but I don't think it's going to work. But this is from YouTube, basically, and this will tell you about the stroke volume variation. Because the pulse pressure variation, we got it through an arterial line. We do the calculation, you know. I mean, I think Ginny, you know, we had this patient next door here, septic patient. We gave him 12 liters,
Yeah.
right?
Yeah.
I mean, you know, we calculated this pulse pressure variation. It was very high, and it was probably like over 20, remember? I mean, and we kept giving him fluid, and recalculate his pulse pressure variation. He received close to 12 liters, you know, to be able to get the pulse pressure variation below 13. If we just rely on this, our sepsis protocol, patient would have maybe gotten like, you know, 4 or 5 liters, you know. So he received 12 liters, you know, because we are like.
How often do you reassess the pulse pressure variation
Very
then?
good. Yeah. So basically, usually I'd like to do it like every 30 minutes, an hour, if I'm doing the manual calculation to assess the response. Now, I was going to talk about the stroke volume variation here,
Okay.
because we have also we have very good technology, you know, that can assess the patient every 20 seconds and give you numbers, which I'm going to talk about it.
Oh.
And I have a protocol also, how we're going to assess it and how often and stuff. So we'll get to it in a second.
Okay.
So this is a video regarding stroke volume variation, which is the same as, you know, the pulse pressure variation. We said the pulse pressure and the stroke volume correlates. But we have some technology here, and this is Edwards, the flow track. It's a nice video on YouTube. It's 5 minutes, you know, it gives you about the physiology. Pretty much the same thing as I mentioned to you about how's the positive pressure, you know, and the LV, and, you know, same thing, you know, but just put it together. So, stroke volume variation. So we have some technologies that can give us, you know, every 20 seconds, the stroke volume, and tell us about the variation. And the same concept of during inspiration, what's going to happen to the LV stroke volume?
It's going to increase.
Increase. Very good. So we're going to have a stroke volume max. We called it before pulse pressure max. Now it's stroke volume max. What's going to happen to the stroke volume during expiration? Decrease. The LV stroke will decrease. So we're going to take those two. We're going to call it SV max and SV minimum. And this is why, I mean, this flow track, Pigileo, has the software, and we'll come up with this formula here based on the sensor in the arc line, and you'll be able to get the variation in the stroke volume. So, stroke volume variation, same formula as the pulse pressure variation, but you don't have to do it manually. The software will give it to you. And same thing, 13% is really the cutoff. It has also good specificity and sensitivity, you know, similar to the pulse pressure. Pulse pressure is a little bit higher, but both of them, they give you the answer. Most importantly, when you have a septic patient, this is a Starling curve. Preload, stroke volume, right? You want to bring your patient from here to here, right? He's volume responsive, from A to B. At the same time, so you want to give him a bolus, fluid bolus. You want to see a large increase in cardiac output, more than 15%, to determine that the fluid was good. You know, so we're going to bring the patient from A to B. And you don't want to see any fluid in the lungs. So basically, from A to B, it's going to increase. You give fluid, the cardiac output is going to get better, and small increase in extra volume lung water. When you get to point B, now if you give more fluid, cardiac output is not going to increase, and you're going to start seeing large increase in extra volume lung water. The flow track will give you this information, including the lung volume, water lung volume. So it tells you where you stand there. I'm going to show you some slides here. So we have some automatically analyzed devices, or flow track, which we have at downtown and cardiovascular ICU. We have PICO, LIDCO, NICOM. I mean, we have lots of devices there. I like the flow track Vigilio, which is very, very good. I included here an article about the state-of-the-art cardiac output monitoring by Paul Merrick. It has lots of details. It's over here. I'd like you guys to take a look also if you have interest. So the Vigilio or flow track, the old device required like frequent calibration. The new one, it has a software that auto-calibrates itself every 20 minutes. But basically, every 20 seconds, it can give you data, accurate data. And this is the data that this one of the screen. You can get data about the preload, afterload, contractility, including the stroke volume variation, lots of detail. This requires an art line to get the stroke volume variation. If you want to get like extra lung water, you need a CVP line to get this, and SVO2 also same. So that's flow track has been proven to be acceptable in assessing cardiac output in patient undergoing CABG. So we have it at downtown. So the flow track has the SVV extra algorithm flow track. So we can use it for patient who has like PACs, PVCs, because it has this correctable algorithm. So for instance, let's say it detects that patient had a PAC or ectomy. It follows the flow, that's why I call it flow track, and it corrected. So it's like a smart software that it will correct those PACs and PVCs for you. Because when patients have a PAC or PVC, the stroke, the contractility is different. So you might get different numbers. But it has a smart technology that it can correct and follows a track, and so sensor sense, it brings to the machine device, and then you get this kind of waveform, and it follows a track. So it corrects itself if there's a skip beat here, so it detect, reject, interpolation, restoration, calculation. But it doesn't work in AFib. That's the only part. So PACs, PVCs, okay, but AFib, it does not work. This is some of the stuff that you can get. This is a tutorial from flow track, and basically, as I said, we have the stroke volume variation, stroke volume. So you're going to know about the stroke volume and the stroke volume variation. So here is 26, and the stroke volume is 44. So stroke volume variation is 26. It's more than 13%, right? So what we do here, we give the patient a bolus. It's given 500 cc. What happened here? Stroke volume variation went down, and stroke volume went up. So responsive. You see, this is a Starling curve. Remember? Yeah. Then let's say you want to do the passive leg raise. We'll talk about it in a second. The stroke volume variation was 23, so he's on point A. Here, for instance, let's say you want to give more fluid. The stroke volume better, stroke volume variation goes down. But look what's happening to the lungs. He's filled up with water. So the patient already is on point B of the Starling curve. So what the software will tell you, let's stop. Are you sure you want to give more fluid? Yeah, so it tells you about the patient has already been oversustained. Wake up.
Please insert another quarter. Game over.
Yeah, so go back to our patient. I told you I'm going to tell you what happened. BUN 75, creatinine 2.6, people of 16. I told Nathan, let's go get the flow track from CBICU. So it was a Saturday, he has some connection. So this is the flow track. This is so we're able to borrow it, for our patient. And basically, this is how it looks like. It's fancy, it gives you the cardiac index. It gives you the stroke volume variation. It gives you the stroke volume by itself, and it has this extra lung water index, so you can see if the patient is getting overloaded. This is like state of the art. And we have it. This is from downtown. You see this phone there hanging? So what we did is and also, if you look at this technology, it's like it has the clear side, which is, you don't need an arterial line, and similar to an ICOM here, so you can stick it to the finger, and it can gives you also stroke volume and stroke volume variation, you know. Also, you know, if you want to get more details, you need to get an arterial line here, okay? But it gives you all this data. It's really amazing technology. Yeah, we'll have to, you know, we speak to, you know, my partners and stuff. Everybody's excited about the idea, so hopefully, I mean, we'll get to that. I mean, I think this is something important, you know, because as I showed you, I mean, we have to have good dynamic tools to assess volume response in those patients, you know. And also it gives you graphics, you know, stroke volume variation, cardiac index, you know. You can see like stroke volume variation goes down, cardiac index goes up. You need to be in this zone here. If you're outside the zone, means you're not yet there, you know. So what we did, our patient here on the column here, on the right column, his cardiac, let's say his stroke volume variation was 14% on people of 16 and stuff. And his stroke volume was 660. Cardiac index was 2.5. So what we did, we did two fluid boluses basically, but you can see after fluid bolus, his cardiac index went 2.5 to 3, 66% improvement in the cardiac index. That's very impressive. To call it an improvement, you need 15%. So this went up from 2 point, you see, minute changes of the cardiac index. Big change. 58% of the stroke volume, 60 to 103. We doubled the stroke volume, you know, which is the most important one in the formula of oxygen delivery and perfusion. Look at the cardiac output, doubled, 58%, you know, I mean cardiac output improvement. You know, so we took the patient from point A to point B. And what happened is, he's off levo, off vasopressor, you know, hours, lab 65, kidney function, you know, you start making urine. You know. So it's important, you know. I mean, because sometimes you don't know, and you feel like it's septic, and you start adding up more. There's also something PICO. I'm not going to go details about it, and I want to get to the bottom of it here. LITCO, it's a Great Britain thing in London. This is a summary table, you know, of most of it, but I mean, the Vigileo flow track is the best at this point, you know, and I think this is really what we have to kind of hopefully try to get here at house. The problem with dynamic measurements, most of the time you need an art line. However, I showed you the flow track, you can do a finger one. But if patient is sick on pressure or so, you need an art line. Arrhythmias, AFib is still an issue. PACs, PVCs, I show you this SV, you know, algorithm, you know. You know, so limitations, sustained cardiac arrhythmia, open chest, small tidal volume, you need to have ATC per kg, spontaneously breathing patient, erratic breathing, you know, it's not going to happen.
So if they're breathing just even a couple breaths over the ventilator?
No, a couple of breaths is okay, but as long as there's no like,
Asynchrony or
erratic
anything?
breathing, you know, it's
Okay.
like fighting the ventilator, bronchospasm, it has to be kind of, you know,
Okay.
a little bit passive, tranquil, you know, and yeah. So moving on to pulse pressure or stroke volume, force positive, spontaneous breathing, but we're not talking about just like respiratory rate of 20, 22, I'm talking about like, you know, 30, 40, I mean, acute core pulmonary, very important. And this is why, even though we're going to hopefully have this technology available, you know, it does not, you still need to do an echocardiogram. You still need to get this probe and look at the RV. If the RV is big, is dilated, then the pulse pressure variation or the stroke volume variation, it doesn't have any value. If you have somebody with core pulmonary or massive PE, you know, the LV is going to be hungry, you know. But this is, pulse pressure, what's going to do is going to give you a forcefully elevated number. You don't want to give fluid there, you know, because it's a forcefully positive test. So, core pulmonary, AFib, spontaneous ventilation, you know. The other ones is like if you have bronchospasm, small tidal volume, or significant increase in intra-abdominal pressure. Stroke volume and pulse pressure, they give similar predicted values. The same, whether you have an art line until we get home with this technology, or you have, you know, the flow track, you know, is pretty much the same. PLR, how many of you guys are familiar with PLR, passive leg raise? So it's like an auto bolus, okay? And the way we do it is pretty much, this one picture here, like, you know, patient in the bed, we kind of raise the bed, flattens the head of bed, like a thread lumbar, and you should have 12% or more, you know. So you want to do it, you want to be able to assess the stroke volume. So you have to have something to tell you about stroke volume, you know. You can't just rely on the mean arterial pressure, you know, somebody who's like septic or so. It is there, it's available, but you have to have a device that will tell you about the stroke volume and where your patient goes from here to here or not. So just by itself, you know, might not be very helpful, especially in septic patients. That might not work. So PLR can be done in patient regardless of the vent mode or cardiac rhythm. So you have patient with AFib, you know. That's one of the problems with pulse pressure variation, you know. PLR, you can do it, but you have to have maybe an echo or something to be able to know that the cardiac output is getting better, you know. But it is there, you know, it's used. Make sure it doesn't have a DVT, you know, that's important. Yeah.
Now, what would you measure the stroke volume with if you're doing that?
PLR, what do I, let's say patient in AFib or which, just the question.
You said you have to be measuring the stroke volume when you do it to be able to get the measurement.
AFib really is a big confounder, you know, I mean, let's say here, for instance, I put this slide. If you have an ETCO2 monitor on the ventilator, you know, for instance,
okay.
An increase in ETCO2 by more than 5%, it indicates positive response.
Oh, okay.
You know, so it goes by 2, because the ETCO2 can be a surrogate for the cardiac output.
Okay.
You know, so ETCO2, PLR, ETCO2 more than 5%. You know, positive response. Look at the pulse predictive value, 95 to 100%. So what else we can do if the patient had AFib? This is a ventilator here. We have this button here. It's the end expiratory occlusion test. So what you do is like we press on this button to get like 15 seconds of end expiration occlusion. And this is how most of the time we check for RP. Okay? And this way you can stress the circulation for 15 seconds. And if you have, but you have to look at the pulse pressure variation. And any increase by more than 5%, this indicates volume responsiveness. If the cardiac index, and the flow track will give you also cardiac index, goes up by more than 5%, it's also indicate volume responsiveness. So in those cases, you know, if you have AFib, and you have a way to check, you know, the cardiac output and the pulse pressure variation, 5% increase can help, you know, in those cases. So the rule of thumb is 15 seconds and expiratory occlusion, 5% pulse pressure variation, 5% cardiac index. You'll be able to tell if your patient volume responsible. Let's see what else we have here. So it even works with high PEEP. Let's move on a little bit here. So let's try to summarize what we've said so far. So fluid management measure. It's a measure, okay, we follow on our patients. When a patient comes to us, we implement sepsis protocol. This is what we call resuscitation. We are resuscitating the patient. And then we have to work on optimization of the patient. We saw our patient, we implement sepsis protocol, then we have to talk about what after, you know, to optimize his condition. Then stabilization. Then escalation or de-escalation of the fluid. So those are the measures we're going to follow. And this is why it's very important, you know, to have some sort of dynamic measurements to accurately know where the patient stands. You know, otherwise, there's no way you're going to get it, right? When a patient comes to the ICU for sepsis, 30 cc per kg. What after? He got the first bolus. So what?
And they always go to maintenance, and what's your CVP?
So what do we know what happened? No. So
That's all.
yeah.
That's all. That was
So
the
this is
best
a very nice article, you know, prediction of volume responsiveness, an updated one. I have it here for you. I really advise you to take a look. And it summarizes also an algorithm in front of an acute circulatory failure, hypertension. So low blood pressure or cardiac output, signs of tissue perfusion. Yes. Is hypovolemia obvious? If it's obvious, then it's no-brainer. It's like, I mean, you know, if not, then you have to look at preload responsiveness. Before you do this, you have to check: is the patient actively, spontaneously breathing? You know, is he in cardiac arrhythmias? Is he in ARDS with low tidal volume or lung compliance? Is the question no? Then you can do the pulse pressure variation or stroke volume variation. Hook him up to the flow track. Okay. You can do the PLR. You can do an expiratory occlusion test. You can do the mini fluid challenge, which means 50 cc's into circulation and see how much the velocity time index. But this is, you need an echo to do that. I did not bring it up here. But those three things here you can do. Sometimes you can look at the IVC if you're a vena cava and see, but this is going to require, it's demanding. We said a good measure is a measure is simple, easy to use, it gives you the answer you know. I mean, it doesn't really complicate things. Let's say the patient had any of those things. So the ones that you're left with, acid leg raise, and expiratory occlusion test, mini fluid challenge, but you need to have a little bit of technology, like you need to have an echo at the bedside to be able to know exactly what's going on here. Here, yes or no. This is another article, non-invasive cardiac output monitor. Pulmonic, it has all the things we talked about, you know, included there. And I highly recommend this algorithm, and I hope this will replace our sepsis protocol down the road. So my colleagues, you know, especially Dr. Fortin, you know, she's involved also, and I think our sepsis protocol needs to be updated. I mean, at some point, in front of a patient who is in any cardiac derangement, attach the non-invasive cardiac output device. Clinical examination hemodynamic variables, hypertension, oliguria, high lactic acid. You can give like a 500 fluid challenge. Check to see the stroke volume variation. They said 10% here because the cutoff is 10 to 15. But if the stroke volume variation goes by, if the stroke volume index increased by 10%, you give 500 crystalloid or colloids, and this will be like on the flow track. You can tell the stroke volume index. If it increase less than 10%, if the increase is less than 10%, MAP below 65, then you can move on to get more indices. Cardiac index is something you can get on the flow track, very easy. And or poor LV function, you know. I'm sorry, let's see. So yeah, you can start dobutamine. So you can start first with like a volume challenge and look at the stroke volume. If you see an increase in stroke volume more than 10%, you can give them fluid, repeat. If you start seeing not an increase in the stroke volume, you can look at the, you know, MAP. If it's below 65, cardiac index less than 2.5, you can start dobutamine. One more thing here. For sepsis, so the other one was more for like maybe cardiac patients or so, but this one for sepsis. This is a protocol for sepsis. So we have to recognize severe sepsis, IV access, 30 cc per kg, standard, with respect to antibiotic stuff. If MAP below 65, then establish central venous access, attach non-invasive cardiac output device. You can start, you know, Levo until you get your data, you know, I mean, ready. Fluid, 500 fluid challenge, or PLR, look at the stroke volume, increase by more than 10%, keep doing fluid. Stroke volume doesn't increase more than 10%, persistent hypertension, high lactic acid. You can look at the cardiac index. You can do bedside echo also and see the pumping. Dobutamine, cardiac index more than 4, stroke volume index more than 40, or hyperdynamic LV, vasopressin, and stuff. So this is something that was suggested in this article, you know. We can modify it, you know, depending on which technology we have, and we can come up, but I feel like this will be after the resuscitation, or until we get to optimization, we have to have some sort of communication, you know, clearly, other than the CVP. But as of now, we say like, okay, CVP 8 to 12, 12, you know, 12 to 15, but we want to get the stroke volume. We want to know about the stroke volume. It's very important, you know. So we talked about the pulse pressures, the dynamics, you know, the dynamic changes. Echocardiography, this is a lecture, you know. I included the RUSH protocol here for you to take a look. I mean, and the RUSH protocol, it's basically the rapid ultrasound in shock patients. Ultrasound is very important nowadays. Every patient with hypertension should have a mini echo, the stuff that you see me doing in the rounds, you know, to look at the LV, see the squeeze, look at the RV, the IVC, you know. This is important to an assessing patient, you know. You see sometimes I look at the veins, you know, I mean, see if there's any like a DVT or so. I mean, this is of course the RUSH protocol, and basically we're going to assess the pump, the tank, the pipes. The pump is the heart. The tank is like the pleural space, the fluid, and the abdomen. The pipes, looking for the DVTs or if there's any aneurysm or so. There is a nice article about intensive care ultrasound through responsiveness. We've done the IVC on those patients, and we use the M mode. You've seen this, and basically you can look at the collapsibility, of the IVC, and this can correlate also with some of the right atrial pressure. Somebody who's spontaneously breathing, you have to see more than 50% collapsibility of the IVC to know that the patient is dry and needs fluid. If somebody is under mechanical ventilation, you need like 18% distensibility. This is side-to-side IVC collapse and right atrial pressure correlation. And the IVC distensibility index on somebody on the ventilator has to be more than 18% to predict volume status. So look, just have 2 slides and I'll be done. Looking at the surviving sepsis campaign, the sepsis 3. So recommendations, we recommend that in the resuscitation form from sepsis-induced hypoperfusion, 30 C per kg, we know that, this is a recommendation. You have to give fluid. We recommend that following initial fluid resuscitation, additional fluid be guided by frequent reassessment of hemodynamic status. And under this recommendation, we suggest that dynamic testing, pulse pressure variation, stroke volume variation, PLR, over static variables be available. We're still waiting to get a protocol put together for the new sepsis guideline to replace the early goal directed therapy. And once we get this also, but I kind of gave you some protocol. I think we can modify it according to it. So, its primary goal, improving in cardiac index, stroke volume cardiac index. Multiple tools at your disposal. No single number should be treated alone. Trends matter. Okay, you have to follow the trend. Early evaluation, cardiac structure, functional echo, is important. Dynamic, continual assessment is required. So we talked about, we know that fluid management really matters here. Judging whether to give fluid or not to give fluid, it can be complex. So you see sometimes like nephrologist, cardiologist, intensivist, everybody is trying to make a decision. We talked about dynamics and what echo, important also. And you need to know that you are prescribing more fluids than you realize. And by this, I'll be closing. Sorry, we went a little bit maybe over.
Oh, that was awesome.
That was very good.
Always teamwork. Now, let me tell you, I have I still have maybe like 100 more slides. I had 218, but I stopped, I think, at 130, And I'll be happy to share with you this lecture, the slides, because there's lots of data on echocardiography and stuff. So I don't mind downloading on one of the computers, and you guys can have those slides, Those are the articles. I highly recommend you to take a peek at those articles, updated articles, and hope you guys enjoyed it.